Greetings and a very warm welcome to all the dignitaries present here. I am Kashish from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. And it is with great pride that Clarinet serves as the digital partner for this event hosted by Indian College of Anesthesiologists. And the focus of today's session is current concepts in cardiac anesthesia, for which I would now like to invite Dr. Muralidhar sir for the further proceedings. So, sir, I welcome you and over to you. Thank you so much.
Good evening and thank you for joining us. At the outset, I would like to wish you a happy Diwali. And as you know, the one of the important hallmarks of ICA activities is this Wednesday webinars, which are very popular. And today we are going to have an update on cardiac anesthesia. There are 5 topics chosen. There will be short presentation on each of them, followed by a discussion time about half an hour. Please feel free to ask your questions or add anything you would like to add or comment at the end of the 5 talks. And it is my proud privilege to invite Dr. Parimala, who is the leading cardiac anesthesiologist in Jayadeva Institute of Cardiac Sciences in Bangalore. Then Dr. Pooja Natarajan, who is again a well-known cardiac anesthesiologist working for the Satya Sai Hospital, North Bangalore. And Dr. Rachna Vadva, again, is well-known figure in the field of cardiac anesthesiology, is very talented in transesophageal echocardiography. Dr. Rachna, thank you for joining us. And I will be with you till the end of the session. And with that, I would request Dr. Parimala to take over and start the sessions.
Thank you, sir. Happy Diwali to all. And today we have cardiac monitoring related topics, and we have eminent consultants from Apollo Hospital, Kolkata, and I'll just read out the details about the webinar today. So there is first topic by Dr. Abhinandan Mondal about pulmonary artery catheter and update. Then deep hypothermic circulatory arrest by Dr. Sohini Mujumdar. Then low flow, low gradient aortic stenosis by Dr. Deb Jani. And PICO monitoring by Dr. Elvis. And TTE as relevant to cardiac anesthesia by Dr. Arupratan Maiti. Can we start the sessions, the lectures?
Yes, please go ahead. Abhinandan, kindly share your screen.
Yes, sir. Good evening, ma'am.
Good evening.
Is my screen is visible to everyone?
Yes.
Thank you so much. So I am Dr. Abhinandan. I wish you a very happy Diwali and a very good evening to all of you and all my teachers. So I'll come up to a topic of pulmonary artery catheter. So it is still a gold standard for cardiac output monitoring, pulmonary artery pressures, mixed venous oxygen saturation, and blood temperature monitoring, even in the era of non-invasive monitoring tools, in spite of so many controversies regarding pulmonary artery catheter use. So there are grossly 3 generations of pulmonary artery catheter since 1970s of Swan and Gans. So it is 1, 2, and 3. In the first generation, there is only bolus thermodilution signal we used to have, And second generation, there was a random thermal signal. And third generation, we are in the era of the third generation pulmonary artery catheters. It's using pulse wave analysis, which gives us the continuous cardiac output monitoring. So what are the variables that all PA catheters provide? It gives the right atrial pressure, pulmonary artery pressure, pulmonary artery occlusion pressure, and intermittently we can monitor about the mixed venous oxygen saturation. But what are the additional measurement that we can measure with your third generation catheters? These are continuous measurement of your mixed venous oxygen saturation, right ventricular ejection fraction, which is very important, and right ventricular end-diastolic volume and right ventricular pressure. So this is a overall anatomy of your third generation PA catheters. We can see that these are 110 centimeter long catheter. As we all know, there's these things. There is a 7 French. Thin lines are 10 centimeter apart and thick lines are 50 centimeter. These are all same as our first and second generations. So in moving forward, tip has a balloon of 1.5 ml volume of 13 millimeter of diameter, which has a balloon inflation valve, which is fitted with a self-limiting 1.5 ml of syringe. There is a 4 centimeter from the tip. There is a temperature detection thermal filament, and also there is a thermistor over 15 to 25 centimeter proximal to the tip for the continuous thermodilation method. And another thing, there is a proximal injected lumen hub that was previously used for your bolus cardiac output monitoring, that is pole thermodilation and CVP measurements. And thermal, there is a optical module for the connector. It is a continuous monitoring of mixed venous oxygen saturation. This is all we know, that this is the 4 waveforms that we actually face while putting the PA catheter. At first, of the upper left image give you the right atrial waveform, that is the central venous waveform. And on the right upper image shows you in the RV waveform, and the PA catheter, the PA pressure waveform that you can see in the lower left, and the pulmonary artery wedge form we can see in the lower right. So these are the continuous hemodynamic parameter that we can see in a most advanced monitoring at present. So what are the monitoring continuous hemodynamic parameters we can see? This is the mixed venous oxygen saturation, which is a continuous thing. Then stroke volume, continuous cardiac output, SVR, right atrial pressure, right ventricular end-diastolic volume, pulmonary artery occlusion pressure, and right ventricular ejection fraction. All the values you can see in that image of a hemisphere. So this is the normal parameters and its normal values that we can obtain from this current third generation of PA catheters. As you can see, the study which was used to be done for against the PA catheter use, right now, what are the enormous amounts of information that we receive from each and every catheter that we put. So even if we don't have the special monitor for this kind of third generation catheters, so in spite of that, if we use that RV port and we transduce it, and we make a overlapping with the PA waveform, we can actually see the RV function assessment from this PA catheter. So at the first image, you can see that this is a normal waveform of your PA catheter and also your RV pressure waveform. As you can see that that RV pressure, actually there is the steepness, it increases whenever there is a RV dysfunction starts. So this steep rise of your RV pressure waveform during diastole of the right ventricle, as you can see in the second image. And also in the third image, you can see that there is sudden square root pattern of your RV waveform, and there is a equalization of diastolic pressure of your RV and your PA in a severe severe RV dysfunction. And if there is a severe RV systolic dysfunction, you can see that there is almost equalization of your systolic pressure and also diastolic pressure, and also there is a slope. You can see that there is a slow upstroke of your RV systolic pressure. So by this, you can see that RV function assessment can be done from the PA catheter. So from the zone, so PA catheter has to be put in the zone 3, because zone 3 of your waist zone, because at that zone 3, the alveolar, because the pressure in the alveolus is lesser than your pulmonary venous pressure and pulmonary artery pressure. So PCWP is equals to left atrial pressure. It is not always, because as you can see that in this image, you can see that if there is any obstruction in this area, so that will not cause any pressure changes in the pulmonary capillary wedge pressure, as there is no flow in this area. But if there is any obstruction in this area, as you can see, let me show. As you can see that if there is any obstruction in this area, this will cause any overestimation of your PAWP. So it will cause a overestimation of your LA pressure. So PCWP is more than in ALV EDP in this scenario. Whenever there is any positive pressure ventilation, high level of PEEP, increased intrathoracic pressure, non-wave zone lung, zone 3 PSC placement, and COPD patients. In case of LV EDP, it is more than your PCWP in case of your non-compliant left ventricle and aortic regurgitation if there is a premature closure of the mitral valve. So application of PA catheter, at present we use for the ASA 4 and 5 patients, high risk surgical procedures, any quantification of left to right shunt, if there is any discrepancy, and evaluation of cardiac and pulmonary transplant, and assessment of RB dysfunction and failure, fluid responsiveness assessment, and differentiating pre-capillary and post-capillary pulmonary hypertension. You can see that these are differentiating point for this pre and post-capillary hypertension. So what are the complications that is the most commonly faced? There's a arrhythmias, most commonly PVC and RBB and CHP. These are all mostly are self-limiting. Endobronchial hemorrhage, excessive balloon inflation is the main cause. Distal migration of PSC can cause during CPB and manipulation. And hypothermia also hardens the PA catheter, which causes this endobronchial injury. And if there is hemorrhage, protection of the uninvolved lung is the main parameter, our motto. And what are the other complications? That is pulmonary infarction, thrombus formation, incorrect position, balloon rupture, and ventricular perforation, and artifacts and erroneous measurements. So thrombus formation is most commonly at the RA level, incorrect position most common, for example, coronary sinus through persistent LSVC. Balloon rupture, air cannot be withdrawn, only blood is aspirated, and if there is a catheter artifacts, we can see it as a catheter weep. So what are the contraindication? There is no absolute contraindication per se. And for a few of the articles that I want to mention, these are 2025 article. These are association of this is a systematic review and meta-analysis of association of PA catheter and surgical patients outcomes. So this concludes that this meta-analysis that this is not associated, PA catheter use of is not associated with short-term mortality in surgical patients, but with a higher incidence of major complications and longer length of stay in the ICU. In the Brazilian Journal of Anesthesiology 2025, this is the modern indications, benefits, and limitations. They have mentioned that the PAC has undergone a resurgence in specific context driven by advancement in catheter technology and refined patient selection criteria. And also the technological advancement combined with rigorous training and adherence to evidence-based guideline can further enhance the utility of PA catheter. Another paper, pulmonary artery catheter monitoring in patients, cardiogenic shock, time for a reappraisal. They have mentioned that Swan-Ganz catheter, whose use was clearly dropped in the past 50 years, is being rediscovered as a valuable tool and may play a role in the steps for diagnosing weaning from the mechanical circulatory support. So what are the take-home message? The appropriate patient selection criteria is the most important. Then surgical risk stratification, whether it's a high-risk surgery or low-risk. Protocol, whether it is to be delayed in insertion or the on-time insertion, hemodynamic management, that is what to be done in whatever the values are there, and training for data interpretation and high fidelity simulation, use of third generation catheters, and availability of specialists and equipments to manage of any complications. And TE and PAC are complementary to each other. So combined use of PA catheter and TE may be more helpful than alone. Thank you. Hello.
Thank you, Abhinandan. That was a wonderful presentation. Hello.
Thank you, ma'am. Thank you, ma'am.
Yeah.
Thank you, ma'am.
We'll take questions at the end. Okay, so we'll move on
Sure.
to Dr. Shohini Majumdar, who is a consultant cardiac anesthetist from Apollo, from BM Birla, right? Sohini, hi, how are
Yes,
you?
ma'am.
All
Hello,
good?
ma'am. Yes,
Yeah.
ma'am.
So today we'll be listening to deep hypothermic circulatory arrest. Okay, all
Yes.
the best. Can you share
Thank
your
you.
slide?
Yes, sure. Is my screen visible?
Yes, yes, yes.
Okay, thank you.
Please put it on slide share.
Yes.
Yeah, that's perfect. Thank you.
Okay, one second. Okay. Okay, so will be, am I audible?
Yes, can you put it on slide share, please?
It is on slideshow. Are my slides moving?
Yeah, it is, but I think that's your background. Okay, no problem. You can go
Okay,
ahead.
yeah.
Thank you.
Okay, so my topic is deep hypothermic circulatory arrest. So a brief introduction. Brain is susceptible to injury within minutes after onset of circulatory arrest because it has a very high metabolic rate. It has continuous requirement for metabolic substrate and limited reserve of high energy phosphates. So at normal body temperature, neurologic injury can result within 4 minutes of circulatory arrest. Classification of hypothermia. So hypothermia is divided into mild, moderate, severe, and profound hypothermia. Mild being between 32.1 to 35 degrees Celsius, moderate between 28 to 32 degrees Celsius, severe is less than 28 degrees Celsius, and profound hypothermia is less than 20 degrees Celsius. Now, why do we need hypothermia? So hypothermia is one of the most important component of deep hypothermic circulatory arrest. Hypothermia causes reduction in CMRO2. So that will result in slowing of the rate of depletion of high energy phosphates and development of intracellular acidosis, which delays or prevents the neuronal energy failure, which can lead to terminal membrane depolarization and subsequently neuronal injury or death. There's a concept of Q10, which is basically the ratio of organ oxygen consumption at a defined temperature to the oxygen consumption at a temperature 10 degrees Celsius lower. So normal cerebral Q10 for children is 3.65, which is a little higher, and in adults it's 2.3. Now the cerebral metabolic rate is approximately around 10 to 15% of its normothermic baseline at 15 degrees Celsius. So if the Q10 is 3 at 37 degrees Celsius, 3 to 5 minutes of cerebral ischemia can be tolerated. And at 27 degrees Celsius, 9 to 15 minutes, while at 17 degrees Celsius, 27 to 45 minutes of ischemia can be tolerated. Hypothermia also reduces the release of excitatory neurotransmitters which accompany cerebral ischemia and subsequent reperfusion. And glutamate, which is an excitatory neurotransmitter, that is very neurotoxic in energy deprived cells because it plays an important role in inducing massive calcium influx via NMDA receptors. And it also attenuates neutrophil migration into ischemic tissue. Now, what are the indications for DHCA? In adults, it is usually used in cases of aortic arch reconstruction surgeries or surgeries like pulmonary end atherectomy. And in pediatric population, it can be used in surgeries of the interrupted aortic arch for Norwood palliation in hypoplastic left heart syndrome, obstructed TAPVD, transposition of great arteries, and surgery on low birth weight neonates who are less than 2 kilos. Now coming to the conduct of DHCA. So DHCA involves cooling the patient's body temperature to 17 to 18 degrees Celsius, stopping the bypass machine and draining the blood from the patient into the venous reservoir and removing the cannulas from the heart. So the cooling involves two types of cooling. So there is surface cooling and then there is core cooling. So surface cooling is effective in neonates and infants because they have a larger surface area and it is initiated once surgical preparation begins. But a very important thing is that it requires close observation of the progress of the operative procedure because premature cooling can result in ventricular irritability, which can lead to dysrhythmias and hypotension. So the surface cooling allows the patient to be cooled to 30 to 32 degrees Celsius before your core cooling begins. So what are the methods which can be incorporated? You can use unwarmed IV fluids, unhumidified gases. You can reduce the room temperature, lower the temperature of the heating cooling blanket, and you can pack the patient's head in ice. Coming to core cooling, which is the most effective cooling, it's done on CPB. Vasodilators like SNP or phentolamine can be added on CPB as the cooling commences to promote vasodilatation and so that there is homogeneous cooling. Most importantly, systemic hypothermia should be achieved slowly, evenly, and completely over no less than 20 minutes and no faster than 1 degree Celsius per minute. What are the endpoints of DHCA? On EEG, it should be isoelectric. Your tympanic membrane or nasopharyngeal temperature should be less than 18 degrees Celsius. Bladder and or rectal temperature should be less than 20 degrees Celsius. And once that is achieved, all your monitoring catheters should be turned off to decrease any sort of air entrainment into the vasculature during exsanguination. Now, these are the recommendations for increasing patient safety margin while utilizing DHCA. So basically, Boston's Children's Hospitals, they conducted many studies on circulatory arrest, and they came up with these kind of recommendations. So the target hematocrit should be 25 to 30%. Like I said earlier, systemic hypothermia should be achieved very slowly over no less than 20 minutes. For blood gas management, pH stat blood gas management should be used at least for cooling to improve tissue oxygen delivery and for even cerebral cooling. We'll discuss about pH blood gas management in later. Core body temperature should be of 17 to 18 degrees Celsius should be utilized, and ice bags should be applied to the head. Hyperoxia immediately before DHCA, it improves tissue loading. Now, DHCA can be divided into periods of no longer than 20 to 30 minutes with reperfusion periods of at least 2 minutes in between, and that has shown improvement in neurological outcome. Regional cerebral perfusion is preferred over low flow CPB for cerebral protection. Cold normoxemic reperfusion of brain after DHCA can be utilized because it will help in restoring cerebral autoregulation and wash out the accumulated metabolites. And normoxemia should be maintained after DHCA because it will reduce the exacerbation of brain injury, and neuromonitoring should be used. Now coming to rewarming. So we are cooling, we should rewarming also. So that should be done gradually, very important, because rapid rewarming can result in systemic gas bubble formation, cerebral oxygen desaturation. Uneven warming can result in cerebral ischemia, and it can also result in hypothermia in the postoperative period, which is a phenomenon called as after drop. So basically, the temperature gradient between the arterial outlet and the venous inflow of the oxygenator during CPB rewarming, it should not exceed 10 degrees Celsius to avoid generation of any gas emboli. This is a class 1 recommendation. And once your temperature goes above 30 degrees Celsius, then the gradient less than 4 degrees Celsius can be maintained. That is reasonable. So like you have a cooling rate, you also have a rewarming rate, and that is around 0.5 degrees Celsius per minute. Now coming to adjuncts to DHCA. So there are pharmacological adjuncts and then there are other adjuncts. So let's discuss about the pharmacological adjuncts first. So you can give propofol or barbiturate. Thiopenton around 1 gram can be used in adults, or propofol 2.5 milligram per kg immediately before initiation of DHCA to ensure a complete isoelectric EEG. Anesthetic drugs like opioid, benzodiazepines, muscle relaxants should be administered prior to DHCA. That minimizes oxygen consumption. Methylprednisolone 30 milligram per kg or 1 gram in adults can be used. It promotes cell membrane integrity and reduces brain swelling. Mannitol reduces potential increase in ICP and reduces free radicals. Magnesium sulfate, lignocaine, and phenytoin 15 milligram per kg can be given for seizure prophylaxis. Now coming to other adjuncts, most important one is the most widely adopted and effective one is antegrade cerebral perfusion, which basically is a CPB technique only that involves antegrade perfusion of the brain through cannulas which are inserted into the branch vessels of the aortic arch. So they perfuse only the brain, and that helps in increasing the duration of the hypothermic circulatory arrest and also provides optimal cerebral protection. So there are two types of antegrade cerebral perfusion, unilateral and bilateral. So unilateral needs a complete circle of Willis. So you cannulate one of the branch vessels of the arch. And for bilateral, so when the circle of Willis is incomplete, you have to cannulate either 2 or 3 of the branch vessels of the arch. So basically in this figure, you can see that we can, for unilateral ACP, we can cannulate either a right axillary artery or the right subclavian or the right common carotid or innominate artery. And in cases of bilateral antegrade cerebral perfusion, all the 3 branch vessels can be cannulated. Now coming to the conduct, so the perfusate temperature should be 10 to 14 degrees Celsius. The flow rate for adults is 250 to 1000 ml per minute, and for neonates and infant, it's 40 to 80 ml per kg per minute. Perfusion pressure in adults should be around 50 to 80 millimeters of mercury, while in neonates, 40 to 50 millimeters of mercury. For unilateral antegrade cerebral perfusion, occlusion of the arch vessels, that will ensure your perfusion of the circle of Willis. Avoid hyperglycemia. Like your normal recommendation, hematocrit should be 25 to 30%. pH management is usually alpha stat for adults and pH stat for pediatric population. And we should leave the SVC line unclamped to the reservoir to get back the return while ACP. And for neuromonitoring, NIRS can be used. So what are the advantages? So ACP has better ability to match the metabolic demands of the brain, better control of temperature, prolongs the safe duration, homogeneous cooling, and more reliable global oxygenation. Disadvantage is that if there is incomplete circle of Willis, so that will result in hyperperfusion of the arch vessels. Besides that, there is risk of arterial wall dissection, embolization, any cannula displacement or kinking, and injury from excessive perfusion pressure. Another adjunct is retrograde cerebral perfusion, which does not need any extra cannulation. You can use the SVC cannula only to selectively perfuse the brain retrogradely. So that will also prolong the safe duration and provide optimal cerebral protection. So for this, your position should be 10-degree Trendelenburg. Why? Because it will reduce the risk of cerebral air embolism and prevent air trapping in the cerebral circulation with open aortic arch. Perfusate temperature should be around 8 to 14 degrees Celsius. Flow rate should be 200 to 600 ml per minute, and the CVP should be less than 25 millimeters of mercury. Again, similar thing, avoid hyperglycemia, pH stat, blood gas management. Here, one thing is that your return blood flow can be monitored through the open aortic arch and is returned to the pump using cardiotomy suction, and NIRS can be used for neuromonitoring. So here you can see like there is actually a Y line from the SVC to your arterial line, which is usually clamped beforehand. Later on, your arterial line gets clamped and the oxygenated blood is given, is administered through that Y line, through the SVC into the brain. Now, advantages are you can provide cerebral metabolites. The most important advantage is that it retrogradely flushes out air and debris from the cerebral blood vessels. So it can be used for management of cerebral embolic events. But the disadvantage is variable amount of oxygen delivery because of the presence of shunt. Then there can be cerebral edema, raised ICP, and low level of substrate supply. Now, the bad effects of DHCA, basically, it causes disruption of the cerebral autoregulation, prolonged CPB, so it can result in coagulopathy. If it becomes more than 60 minutes duration, neurological complications like chorioathetosis, seizures, coma, hemiparesis have been noted, and DHCA have been known to potentially damage the basal ganglia. Now, a brief discussion about the alpha and pH stat blood gas management. So what happens is during hypothermia, there's one concept that your carbon dioxide solubility in blood increases, right? So your carbon dioxide solubility will increase. So your partial pressure of carbon dioxide will decrease and partial pressure of carbon dioxide will decrease. So your pH will increase. Okay, and also another thing that the reaction that is your water breaking down into H plus and OH minus ion, if this reaction is inhibited, so your H plus ions will decrease and your pH will increase. Okay, so what happens is alpha and pH stat are basically different strategies of blood gas management. Suppose on CPB, you are taking a sample from the CPB machine, blood sample, and you're putting it in a machine, ABG machine. So the machine will warm that sample to 37 degrees Celsius, irrespective of the temperature, and then it will give you a value of pH, PCO2, PO2. So these values which you're getting is temperature uncorrected values. Now, if you put it on a nomogram for that particular temperature, you will see that the pH becomes alkaline because the solubility of your carbon dioxide will increase and your PCO2 will decrease. So your pH will become more alkaline. So this is basically the alpha stat method where no carbon dioxide is added to the circuit. pH stat method basically means that you have at any sort of temperature, pH and PCO2 has to be maintained at that particular body temperature. So if in hypothermia temperature, the pH and PCO2 has to be maintained. So the carbon dioxide is added to the ventilating gas mixture. So once you're taking suppose you're taking blood sample from the CPB machine, the machine is warming the sample and reporting it at 37 degrees Celsius, you will get an acidotic value. So why pH stat is preferred? Because of this carbon dioxide addition, there is increase in the cerebral blood flow. So there will be more homogeneous cooling. But also there is one disadvantage that there will be increased chances of microembolization, increase in ICP and cerebral edema. So we use the temperature corrected values during cooling and rewarming, or especially during cooling, we can go for pH stat, and while during in between, alpha stat management can be used. Thank you.
Thank you. It was a really comprehensive lecture, and I think you have covered almost everything, the right from the indications, alpha start, pH start, and we will cover the questions at the end. Thanks a ton for this lucid talk.
Thank you, ma'am.
Now I would like to invite our next speaker. She's Dr. Devjani. She's a very accomplished cardiac anesthesiologist. At present, she's working as a consultant in Peerless Hospital, Kolkata. She's a product of SSKM, Kolkata. We're looking forward to your talk, and I now, pass on so that no time is wasted, and we pass on to next talk.
Thank you very much, ma'am, for those kind words. I hope I am audible.
Yes, you are audible.
Thank you, ma'am. So, very good evening to my respected senior teachers and my colleagues. I would like to talk about low flow, low gradient aortic stenosis. So, whenever we talk about stenosis across any valve, we generally talk of a high gradient across that valve and a high flow. However, the term there, low flow, low gradient aortic stenosis, therefore sounds kind of like a paradox. So, if we look at the classification of aortic stenosis, we can see that as the degree of stenosis increases from mild to moderate to severe, the aortic valve area progressively declines, whereas the aortic jet velocity and the mean gradient across the valve tends to increase. So, in case of a severe aortic stenosis, we can see that the aortic valve area is less than 1 centimeter square, indexed it is less than 0.6 centimeter square, whereas the mean gradient in millimeters of mercury is greater than 40, and the jet velocity in meters per second across the valve is generally more than 4 meters per second. However, in a small subset of patients with aortic stenosis, echocardiographically it has been seen that these patients have a low forward stroke volume across the valve. This low transvalvular flow leads to essentially low transvalvular gradients across the valve. So, in these cases, estimation of the severity of aortic stenosis solely on the gradient across the valve is not possible. If we look at the ACC-AHA classification of aortic stenosis, we can see that the low flow, low gradient variants, they appear right here in the symptomatic severe aortic stenosis. So no doubt these patients are symptomatic, they have severe aortic stenosis. However, if we look closely, we will see that all these patients, they have anatomically severe leaflet calcification with reduced leaflet motion. These patients are also symptomatic with symptoms of heart failure. The echocardiography in case of this classification class D2, low flow, low gradient aortic stenosis with reduced ejection fraction will show a small aortic valve area of less than 1 centimeter square. However, the resting aortic Vmax is less than 4 meters per second and the mean gradient is less than 40 millimeters of mercury. So a low flow, low gradient. The ejection fraction also comes to less than 50%. There is another variety, which is the symptomatic low flow, low gradient aortic stenosis with normal ejection fraction. In this case also, there is a low aortic valve area. The gradient is less. The flow across the valve is also low. However, it is also seen that the stroke volume index is less than 35 ml per meter square across the LVOT, measured when the patient is normotensive. In these patients, we will find some diastolic dysfunction, usually of a higher grade, and the ejection fraction is seen to be normal or near normal. So type D2 is known as the classic low flow, low gradient aortic stenosis, while D3 is known as the paradoxical low flow, low gradient aortic stenosis. Let us see how it happens. First of all, why do you need to know about this entity separately? Because it poses a diagnostic dilemma for the physician. We have to know whether this is a true aortic stenosis which is causing the LV dysfunction, or is it the other way around, that it is basically a dilated cardiomyopathy with a calcified valve that is actually not severely stenotic, because both of these entities will have entirely different treatment plans. So a low flow, low gradient aortic stenosis, if it occurs due to compensative mechanism to the aortic stenosis primarily, with a reduced ejection fraction, we have the classic low flow, low gradient AS. With a preserved LV, we have the paradoxical low flow, low gradient AS, presenting like a HFpEF. However, it can also occur due to some coexistent pathologies, such as if there is a severe aortic stenosis along with a triple vessel disease leading to an ischemic cardiomyopathy, or if there is any other associated lesion. What is the pathophysiology of a low flow, low gradient aortic stenosis, the classical variety? In this case, the long-standing aortic stenosis leads to LV outflow obstruction, which obviously leads to increased left ventricular systolic pressure. In the long run, this increases the LV mass and causes myocardial fibrosis. So this LV hypertrophy is associated with an increase in the capillary density. However, the capillary density increase is never proportionate to the increase in musculature, leading to an oxygen supply-demand mismatch. The layer of the myocardium most affected is the subendocardial layer, and this chronic subendocardial ischemia leads to an interstitial fibrosis. This myocardial fibrosis causes a reduction in contractile mass and increased stiffness of the myocardium. This may lead to afterload mismatch with reduced left ventricular contractility in the long run, with a lowering of the ejection fraction. So essentially a valvular HFrEF, heart failure with reduced ejection fraction. So as the flow across the stenosed aortic valve decreases, the ability of the valve to open reduces. So the calculated aortic valve area will be low, and the flow velocities will decline along with the stroke volume. So the measured pressure gradients also drop. So this is a low flow, low gradient severe aortic stenosis. In case of the paradoxical low flow, low gradient AS, there is excessive left ventricular hypertrophy in response to the hemodynamic stress, leads to a small LV cavity, similar to those seen in severe diastolic dysfunction. So there is low stroke volume despite the preserved left ventricular ejection fraction. So essentially a valvular HFpEF. It is more prevalent in women and elderly patients. Although the ejection fraction may be normal or near normal, the strain, if strain study is done, GLS may be, the global longitudinal strain may be significantly reduced, and it represents an advanced stage of the disease. So it is no wonder that it is important to diagnose low flow, low gradient aortic stenosis at the earliest possible. The methods most commonly employed are the stress echocardiography methods, out of which dobutamine stress echo or DSC, a low dose DSC, is the most commonly employed method. We can also go for CT calcium scoring. As an adjunct, we should also measure the stroke volume index and the global longitudinal strain. And obviously, cardiac MRI can be done for assessment of myocardial fibrosis. Coming to dobutamine stress echo. So low dose DSC is employed to distinguish true severe from pseudo-severe aortic stenosis. It was first demonstrated by D. Philippi et al. And it is a class 2A level recommendation by the SCC-AHA guidelines as well as by the ESC guidelines. So what do we do in the low dose dobutamine protocol? First of all, we have to attach all relevant monitors to the patient and keeping all resuscitation apparatus ready. We first measure the baseline left ventricular function, the gradient across the valve, the LVOT, the aortic valve area, stroke volume, wall motion. So after that, we start dobutamine at a low dose of 2.5 to 5 mics per kg per minute. We increase the dose of dobutamine every 3 to 5 minutes by 2.5 to 5 mics per kg. So at every increment, we should measure the same parameters, that is the gradient across the valve, the aortic valve area, the stroke volume, and the LV function. Now, in case of aortic stenosis, this is where we stop, that is at a low dose up to 20 mics per kg per minute. So when do we stop the test? If we reach the maximum dobutamine dose, irrespective of the result achieved, or if a positive result is obtained at a lower dose, or if the patient is having intolerable side effects like tachycardia, hypotension, or significant arrhythmias. So what is the mechanism of DSC? It basically recruits the myocardial contractility in the normal and hibernating myocardium. That is, it activates the stroke volume reserve. What is a stroke volume reserve? If the patient has a more than 20% rise in stroke volume at peak dobutamine levels, it is referred to as the patient is referred to as having stroke volume reserve. So there are two possible outcomes. In case of a true severe aortic stenosis, where the valve is truly stenosed, that is, there is a fixed stenosis, there will be little or no change in the valve area. However, the gradient across the aortic valve will increase because of the positive inotropic action of dobutamine. In case of a pseudo-severe aortic stenosis, there will be no change or very little change in the gradient across the aortic valve. It will never exceed 40 millimeters of mercury. However, the valve area may increase. So obviously, because it's an echo-based diagnosis, alignment of the Doppler beam to the aortic valve and LVOT is of paramount importance, and correct estimation of the LVOT diameter is also very important to get the correct values. Now, in some patients, about 15 to 20% of this subset of patients, the result of DSE may be inconclusive, or these patients may not be candidates for DSE. So, also in patients with paradoxical low flow, low gradient AS having very small LV cavities, they may develop dynamic LVOT obstruction and hypotension when subjected to DSE. So, the alternative method to assess aortic stenosis severity is the multi-detector CT scan without contrast. What the CT does is a quantification of calcium distribution along the AV leaflets. Now, it has been seen that the calcium burden along the aortic valve leaflets corroborates with the severity of aortic stenosis. Now, for the same degree of aortic stenosis severity, women tend to have less calcification than men. So, the values for women and men are different. We'll come to that. So, the MDCT scan is done during trained end inspiration breath hold, and radiation exposure is generally not very high, less than 3 millisieverts. The amount of calcification in the region of the aortic valve is quantified using the modified Agatston method. So the advantages of this test is that it is an anatomical test and it is independent of hemodynamics. That is, we can avoid all the adverse effects of applying a positive inotropic agent in a patient of aortic stenosis. And the aortic valve calcium score strongly correlates with the hemodynamic severity, the progression rate, and the clinical outcome in aortic stenosis patients. The disadvantage is that CT is essential in assessment of calcification, so it grossly underestimates the valve fibrosis and significantly underestimates severe AS in younger patients. Now, the study was done true or pseudo severe aortic stenosis and published in Circulation, which talked about the projected aortic valve area. In patients where the DSE is inconclusive, what can be done is the diaphragm stress echo can be done in these patients. For at first, the rest aortic valve area and the rest flow across the valve is assessed. Then at the peak dobutamine level, the aortic valve area and the flow across the aortic valve is again assessed. If this is plotted along a graph with the transvalvular flow rate along the x-axis and the aortic valve area along the y-axis, and this straight line is extrapolated to intersect the normal flow rate, which is considered as 250 ml per minute, then what we get here is the projected aortic valve area, which will put in this complicated equation. And if the projected aortic valve area is calculated in patients who are showing inconclusive results on DSE, it is seen that it is a better predictor of the actual hemodynamic severity of the valve stenosis and the clinical outcome of patients with classical or paradoxical low flow, low gradient AS. So it is a better prognostic indicator also. A projected aortic valve area of less than 1 centimeter square confirms the presence of true severe aortic stenosis. So this is more or less the diagnostic protocol that we have. In a patient who's having a low flow, low gradient aortic stenosis with injection fraction of less than 50%, we'll first go for a dobutamine stress echocardiography. If the mean gradient and the flow across the valve increases with the valve area remaining same, that is less than 1 or index less than 0.6 centimeter square, then it is a true severe aortic stenosis. If the valve area remains less, but the gradient also remains less, then the result may be considered to be inconclusive. In this case, we have two options. We may calculate the projected aortic valve area, which if it is less than 1 centimeter square, once again, it's a true severe aortic stenosis. If it is greater than 1 centimeter square, then it is a pseudo severe aortic stenosis. That is, it is a type of dilated cardiomyopathy with aortic valve stenosis, where the valve stenosis is not severe and the symptoms are not because of the stenosis of the aortic valve. And these patients should go for heart failure therapy. If the stress echo is not feasible or inconclusive, then we can go for the aortic valve calcium scoring by MDCT. If the value of calcium score is less than 1200 Agatston units in women and less than 2000 in men, it is a pseudo-severe aortic stenosis. If these values are respectively greater than 1200 in women and greater than 2000 in men, there is a true severe aortic stenosis. So how do we manage? Obviously, you can see that the management is similar to severe aortic stenosis. So whether it is a true the classical low flow, low gradient aortic stenosis or a paradoxical low flow, low gradient aortic stenosis, the treatment of choice is aortic valve replacement, whether surgical or TAVI depends on the, it may be individualized to the patient condition. And it has been seen that the best prognostic outcome is obtained with aortic valve replacement. That is all I have for today. Thank you very much for your patient hearing.
Thank you.
Thank you.
Thank you for that lovely talk. You have summarized the topic very effectively. Thank you so much. Now we go on to the next talk. This is by Dr. Elvis. Elvis, can you please share your screen?
Yes, sir. 1 second. So, am I audible?
Yes, yes, yes.
Okay, sir.
Elvis, as is mentioned, this slide is Associate Consultant Cardiac Anesthesiology at Apollo Multispecialty Hospital, Calcutta. And his interests are cardiac physiology and echocardiography. Thank you, Elvis. Please start your talk.
Yeah. Good evening, everyone. So, 1 second. Yeah. So there's no disclosures. I'll be talking about PICO today. So with PICO, we are going to have to mainly talk about cardiac output monitoring. Now, it's a common scenario where you encounter low blood pressure and then you're like wondering, so do you give more fluid or do you give more inotrope? So that is where you have to think about it, because a fall in the blood pressure is, the map is dependent on both the cardiac output and the systemic vascular resistance. Now, knowing which of the two will alter your treatment, because you will give too much fluid and that will cause a lot of problems, especially in cardiac patients, but in all patients, too much fluid is bad. So that's why we have, there's a lot of talk about goal-directed fluid therapy. Currently, the name has even changed to become goal-directed therapy or goal-directed hemodynamic therapy. Now, if you look at all the parameters and you want to make like a really rational decision, you're going to have like, a bigger flow chart, a more complicated things, but you want more data. So only with more data will you be able to make a better, more tailored clinical decision. Just having blood pressure or CVP will only get you so far. And in addition, one point you have to keep in mind is that almost always there will be more than one condition coexisting in a critically ill patient. So you can't just like think in terms of hemorrhage alone. You can't just think in terms of sepsis alone. You'll encounter a mix of these problems, especially when you take like a cardiac surgery patient. So you want something which is more than just like someone saying, okay, I think this is so, I feel like we need more fluid, or I think we need more NORAD. You don't want something which is like every patient you just like give 6 units of fluid. And there is a traditional way where you ask the surgeon, touch the PA, is it soft, is it hard? There have been studies which show that that is not really a reliable method. And okay, there's the other common thing which cardiac anesthetists use is, okay, the heart looks empty, let's give more fluid, or the heart looks full. But again, we want to move on to a stage where like we are more based on actual data and evidence, not based on like more subjective parameters. So at the end of it, like, you're just going to have 4 knobs to turn. You want to give more fluid or less fluid, or sometimes even remove it. You want to add on vasopressors or inotropes, or sometimes you want to give some blood products. Now, Jane Austen has said that, like, you may know her words, but you can't understand her heart really well. In cardiac patients, you can know the patient's BP easily. It's not as easy to find out the cardiac output. So let's see how we can get to cardiac output, like, monitoring. So PICO is a technology which uses 2 things: pulse wave contour analysis and transpulmonary thermodilution. Now I'll talk about each of these in turn. Now, pulse wave analysis is basically when you transduce a arterial catheter, you get a waveform like this, which almost all of us are familiar with. Till the dicrotic notch, it's going to be systole, and after that is the diastolic part. Now, depending on various conditions, you will have variation in the waveform. Now, if the stroke volume increases, yeah, you're going to get a larger waveform. If your compliance decreases, you're going to have a sharper waveform because the aorta is less compliant. If the SVR changes, again, it's going to change. Now we want to talk mainly about stroke volume. So you're going to have to rule out these 2. So the really smart minds have come up with this complicated model. They call it the 4-element Wynn-Kessel model. So you have the SVR, which is like the arterioles, which are going to cause the resistance. you have the capacitor, which is going to be the iota, which expands and contracts like with an increase in the flow. So that is going to reduce the thing. So this capacitor is going to affect the compliance. Now you have the inductor, which is like the inertia of the blood. And I don't want to bore you too much with the physics. Just know that it's like a little complicated. And the ideal part is from the variation in the stroke volume, from the variation in the waveform, you want to identify what is the stroke volume. Now the pulse wave analysis, because of its complicated and multifactorial dependence, it's very good at telling you about the trend, but it by itself, it does not tell you a precise number, like what is the cardiac output, what is the stroke volume. So for that, like you're going to have something which is going to calibrate it. So you're going to measure the cardiac output through some other method, like in externally calibrated, we measure it with some other method, and then you peg it to the waveform, and then you say that this waveform is equal to this much cardiac output or this much stroke volume. And from the stroke volume, we calculate the cardiac output. So this can be externally calibrated, like in Pico and Volume View, which is the technologies which two different brands, but the same technology which we are talking about today. LiDCO uses lithium dilution, which is similar. Internally calibrated methods use more complex proprietary algorithms, which you're going to have to trust the manufacturer to get it right. And that is these three things, FlowTrack, ProAQT, and LiDCO Rapid. So they are not as validated and they're not as sure. And non-invasive, we have finger clamp. These are more used in like less critical scenarios or in not cardiac cases where you are able to, rule out more of the aortic or other pathologies. Now coming to Pico, so let me see if I can get the laser pointer. Okay. So in Pico, we are going to use the pulse contour to measure the cardiac output. That's PCCO. So now we are going to do two main things. In the waveform, we are going to measure the area under the pressure curve in systole. So this is going to give us that. And this shape of the pressure curve is going to be some parameter which the machine is going to take. Now the heart rate the machine will see. And this is all like, integrated and like there's some complex math going on. The main thing we want to talk about is this cal. So this patient specific calibration factor. Now this we are going to measure with thermodilution. And that we are going to titrate and make sure that the cardiac output we get is going to be more accurate. Now this calibration is going to be, I'll talk about it more later, but that will depend on the patient. And in the same patient, you put him in a different position, in a different volume status, the calibration factor will change. So that is why we need this Pico. Now coming to transpulmonary thermodilution. So basically what we do is we are going to inject cold fluid into the venous circulation, and then we are going to see how long and how the arterial temperature changes at a distant point. Now this distant point is usually a femoral artery cannula where a thermistor is placed in the artery. So now we can see at the baseline, this left-hand side, the y-axis is going to be the difference in the temperature, the change in the temperature from the baseline. Now, once you inject a cold fluid, the temperature will actually decrease, but it will not decrease immediately. It's going to take some time for it to circulate, cross the, the cardiac chambers, and then enter the LV, then the aorta, and then get to your femoral artery thermistor. So now from this, we can calculate the area under the curve, and there's a Stewart-Hamilton equation. Due to time constraints, I'm not going to go into it, but that's like a lot of math. So this will tell you what is the cardiac output. Okay. So from this, we can measure the cardiac output after injecting this cold saline at a particular point. Now the problem is that we can't continuously inject cold saline. One, cold saline may cause arrhythmias, which it will transiently cause. It's usually okay if you inject it once or twice, but if you do it continuously, you're going to have problems. And the two is that you're going to introduce a lot of fluid. So instead what we do is we inject cold saline once or twice or thrice, and then we calculate the cardiac output. And then using that, we calibrate the pulse wave analysis, and we use a pulse wave analysis to measure our cardiac output continuously. Now this cold fluid is injected intermittently to calibrate it alone. Now this calibration occurs once every 8 hours or so, or if there is a major change or you're having some questions about the values. Now, in addition to this, by using this transpulmonary technique over the cardiac, just the pulmonary artery catheter, we are going to measure how much time it takes for the blood to transmit from the RA to the RV to the pulmonary artery, the veins, and the LA and the LV. Now, when it crosses all of this, we are able to get two additional information, which is the mean transit time and the exponential downslope time, through which we get some more volumes. And through this, we can measure what is the global end diastolic volume. Now, the GDV is nothing but the volume of the 4 chambers of the heart alone. So it's LA plus LV plus RA plus RV volumes. So this is a very good indicator of the preload, and multiple studies have validated that this is correlated very well with the preload of the heart. Now, in addition, we also can measure the extravascular lung water. There are some calculations into how these are all derived, but I'm not going to go into it. It's not really needed for us. Just know that by these extra data we collect from this transpulmonary thermodilution, we get GEDV and the EVLW. Okay, now comparing this to pulmonary artery catheter, like my senior Dr. Abhinandan has said, pulmonary artery catheter is the gold standard. So why do we want PICO? So the advantage is that it is not as invasive as a PAC. And the other fact is that you can have an arterial line in for longer than a PAC usually. Usually a PAC, you don't want it more than 72 hours. Whereas with an arterial line, you can keep it for up to a week without issues, and even longer if you take better care and you make sure there's no issues. Now, there are some advantages and disadvantages. I'm not going to go into all of it fully because there's a time constraint, but just know that like you get like a few extra values which are GEDV and EVLW, but you're not able to get a there are a few edge cases where the pulmonary artery catheter will be more accurate than a PICO, especially when it comes to intracardiac shunts or aortic regurgitation or such issues. Now I'll talk about like what actually is a PICO. So far we are just going into theory. I'll just go into practically what it is and how do we insert it. So these are the components. So the first one is a venous injection or temperature probe, which is this blue piece. Then you have the cold saline injection port, which is a piece of plastic which attaches to the distal port of your central line. Then you have this arterial temperature monitor, which connects to the orange port in your monitor, which is the main PICO cable. And then this is a arterial transducer cable, which is working as normal. So here you can see, which is at the bottom, you can see the actual PICO arterial cannula. It is similar to a normal cannula, just that it has an extra cable which comes out at the top. So I'll show you where we attach this cable, and this is all the difference there is. Otherwise, this arterial cannula is going to be inserted the same. So you use the Seldinger technique, and usually you place it in the femoral, but even axillary and brachial arteries have been documented. So the main difference is, as you can see here, once a cannula is done, you have two cables. One is the normal port, which you connected to the transducer, which you can see on the right. And this transducer is connected with a cable to the monitor as usual. So this is the usual pressure. This is a pressure transducer as per normal. Only thing is you want to use the one given with this set, with a PICO set, because it's going to have a higher resolution. So you connect it, aspirate and flush it, zero the lines as usual. Next thing you want to do is there's an extra line and you want to connect it to this cable, which is coming from this large port with an orange marking on top. Okay, so this is the thermistor which measures the temperature. So for the venous, you have So you have a plastic injection port, and this has a blue connector which you attach to the plastic injection port, and the other end of the blue thermistor is connected to the orange device as such. So first thing you want to do is enter the patient details, zero the arc line and the central line. You want to measure the CVP and remember it. Now next you go to the PICO screen and you enter the PICO screen and you enter the CVP value. You press the settings and you get this screen. In this screen, you're going to have the location of the arterial line, the location of the venous line, and you want to specify it because that's going to alter your variable, how the machine measures it. And you want to focus on this, the injection volume. So that is going to play a central role. Here's a short video showing how you start. It tells you to inject 20 ml, and then you want to inject it slowly and gently through the distal port of the central line, through that injection cannula with the blue temperature probe. So once the machine detects that you have injected it, so you will get a next screen. Now, one thing you want to do is you want to inject 2 or 3 times to get a good value of the cardiac output. So if you do 3 times, up to 5 times you can do it, and you will average that and you will get a cardiac output. Now this is calibrated to the pulse wave which is going through the arterial line, and the machine decides, okay, this shape of the pulse wave is equal to this much cardiac output. So if the next wave is smaller, that's a lower cardiac output and so on. I'm simplifying it, but practically for your sake, If you calibrate it, the machine will automatically give you the cardiac output. Now, usually we don't talk about cardiac output directly, but we want to talk about cardiac index, which is nothing but the cardiac output divided by the body surface area, so that we can equate it between different patients. Like you have a really tall patient with a lot of weight, or you have a shorter patient who's very thin. So the cardiac index is going to be more reliable to communicate and go through an algorithm. So yeah, so you, in addition to the cardiac index, you get the other values, which we'll talk about more. But okay, you finally, after all these steps, you have gotten the pico catheter working, the thermodilution is used to calibrate it, you have the values. So we are done. No, we're just going to get into what each of the parameters are. So the cardiac index, like I told you, it's cardiac output by the BSA. So different people use different values. You want somewhere between 2.5 to 5. 3 to 5 is more ideal, liters per minute per meter square. Remember, whenever you have the per meter square, you're going to talk about something indexed to the body surface area. Now the stroke volume index, stroke volume is actually what is measured. It is multiplied by the heart rate to get your cardiac index. So next is the global end diastolic volume, which is indexed. This is a pretty good marker of your preload. So you want it somewhere between 650 to 800. So if you have higher, you mean you have too much preload. If it's low, then your preload is low and you can go with some fluids. Next is the stroke volume variability and pulse pressure variability, which is a whole entire topic on its own. I'm not going to go too much into it, but a value less than 10 indicates that, there is not a fluid overload. So you can give some fluids. Sorry, I said it wrong. So a value less than 10 is a more ideal. If the stroke volume variability is high, then you might think about the patient being fluid responsive. Next is SVRI. Now, one point to note is that SVRI is the MAP minus CVP by the cardiac index. So since the cardiac index is in the denominator, SVRI is actually the SVR into the body surface area. And if you get the value in Wood's unit and multiply it by 80, you will get the value usually seen on the monitors, which is around 1700 to 2400. And the unit is important, dynes second centimeter minus 5 into meter square, not divided by meter square. Now, these are a few new upcoming parameters. GEF is nothing but the stroke volume into 4 divided by the global end diastolic volume. Now, this correlates pretty well in studies to the ejection fraction of the heart. So if you see the GEF fall in the middle of a procedure or during somewhere, then you can say with a pretty degree of certainty that the EF has decreased and the contractility of the heart has fallen. And it also tells you something about the contractile state. So if the GEF is low, you might consider going with a inotrope or even an inodilator, depending on the state. Now the CFI is a cardiac function index, which is a preload sensitive indicator. It's a preload dependent indicator of your cardiac function, which is nothing but the cardiac index divided by the GEDV. So you want it somewhere between 4.5 and 6.5. This tells you something about the contractility and how preload dependent the heart is going to be. And finally, cardiac power index is a new tool. So it is a cardiac power output divided by the BSA. It has been shown in studies to be the strongest independent predictor of hospital mortality in patients with cardiogenic shock. So if you can calculate the CPI and it is less than 0.5 watt per meter square, then you are looking at a heart with a very poor prognosis. So then you will have to consider what is the outcome. So this is a very good prognosticating factor. It's not going to help you with the management as much, but it tells you about the state of the heart and the contractile nature of the LV. Now, in addition, we can get some lung parameters out of this. I'm not going to go into too much detail. Just know that the extravascular lung water index tells you how much fluid is in the lungs. So basically, if the EVLWI, which increases, then the postmortem, the lung, they measured it and then they found that it's heavier. So basically, this word is a tongue twister. EVLWI is an indicator of how much fluid is in the lungs. Now, if you know that there's pulmonary edema, the EVLWI is more than 7 ml per kg, or worse, it's more than 10 ml per kg, you're sure there's water in the lungs. The PVPI, which is the permeability index of the pulmonary vasculature, it tells you whether it is due to cardiogenic or non-cardiogenic cause. So if the PVPI is less than 3, then you're thinking it's a cardiogenic cause. There's no problem with the pulmonary vasculature or the capillaries. It's a problem with your LV function. If it is more than 3, then it's more likely that it's due to a primary lung pathology such as ARDS. So these are two things which have a whole load of uses apart from cardiac cases, but I'm not going to go too much into this. I'll share some resources at the end of the slide. Now, this is a basic algorithm. So you're getting a patient in the ICU. You want to know what is to be done. Do you give fluid? Do you remove fluid? So first thing you want to look at is the cardiac index. So this is a basic algorithm. It's a little, superficial in the sense that this field is very deep, but it is pretty useful, at a glance. So that if the cardiac index is low, then less than 3, then you're thinking of a low cardiac output state. Less than 2.5 is used by some people, less than 3 is some, but usually if it's more than 3, you can be thinking, okay, the cardiac output is good, but something else is the problem. So if the cardiac output is less, then you want to see if the preload is good or not. If the cardiac output is less and the GEDI is less than 700, that is probably a problem with your preload. So your preload is low. So if the preload is low, then you want to go with some fluid bolus, especially if the lung water index is low. Now, if the lung water index is high, then you might be thinking, a bit more judicious with the fluid and add a catecholamine. Now, if the preload is good and the lung water index is low, then you just go with a catecholamine. If the preload is high, but your ELWI is high, then you're likely on the distal part of the Frank Starling curve. So you want to consider diuresis. You want to reduce the fluid load and plus minus a inotrope or a vasopressor. Now, if your cardiac output is good, but the preload is low, then you can think about fluids. If your cardiac output is good, but your parameters, the preload is good and the ELWA is low, then the patient is fine. If the cardiac output is good, but the extravascular lung water is high, then you might want to diurese or reduce the fluid. Now, this is just using some parameters and you always treat the patient, not the values. So always consider other data like SCVO2, lactate, how is the tissue perfusion. Nowadays, we talk about capillary refill time, which is very good. So these are the basic targeted values of GEDI, ejection fraction, CFI, and ELWI. And finally, you might always consider volume responsiveness, PLR. You want to go with dynamic parameters such as SVV, and you want to do an echo and check the contractility. So quickly go through some contraindications. So arrhythmias are going to alter the waveform, so you're not going to have a reliable measures. IABP is going to alter the so many factors, and the waveform is not at all normal. So you're not going to get a value out of the pico. Now in aortic aneurysm, we talked about the capacitance of the aorta. So in aortic aneurysm, there is going to be a gross change in the capacitance. So the waveform is not usable to measure the cardiac output. The waveform is still useful as a trend, but it is not going to be reliable for cardiac output. Now in ECMO, there is loss of pulsatility, especially in VA ECMO. So if you use a cardiopulmonary bypass or a VA ECMO, then there is no use of a PICO because the waveform is altered. Now in pneumonectomy, you can still get some cardiac output, but the other values which are GEDV and the EVLW are not going to be reliable. Now massive P is going to be resemble a pneumonectomy, so that's also there. And finally, intracardiac shunts, all of the thermodilution methods don't work, so that is a contraindication. It's not a contraindication for using the device, but just know that the value is not going to be anywhere near accurate. Now these are the references, and thank you.
Thank you, Dr. Elvis. Next, we have a talk on transthoracic echocardiography relevant to cardiac anesthesia by Dr. Arupratan Maiti. Over to you, Dr. Aru.
Thank you very much. Good evening, everyone. I'll go a bit slow. My topic is transthoracic echocardiography as relevant to the cardiac anesthesia or cardiac anesthetist. I have no conflict of interest, no disclosures. And this article published in 2017 in Indian Journal of Anesthesia. I actually like this article and I've taken few boxes from this or few reference you can say from this article. So last year in 2024, Dr. Tempe published an article, an editorial in the Annals of Cardiac Anesthesia saying that Perioperative transthoracic echocardiography by the cardiac anesthesiologist is the need of the hour. Basically, all of us, who are the cardiac anesthesiologists, we are the perioperative physician, and we do echocardiography preoperatively, intra-op, and post-op. It's a fact that we are more expert or more comfortable with the transesophageal echocardiography, but the days are coming, and we have to do or use more and more transthoracic echocardiography also, because in 2019 the American College of Cardiology uh, approved the concept of limited transthoracic echocardiography being performed by the non-cardiologist, and that also includes the anesthesiologist. So it's true that perioperative TTE by the cardiac anesthesiologist or anesthesiologist is in need of the hour. And this article came in European Journal of Cardiovascular Medicine in 2025 February, and what they found that transthoracic echocardiography can be used as a replacement of pulmonary artery catheter to predict change in blood pressure, afterload, and cardiac output during induction of anesthesia in a non-invasive manner. Obviously, the transthoracic echocardiography, uh, we can't use it intra-op, and but in some cases, as an anesthesiologist, if you think that the condition has changed, you need to check the volume status, you need to check the contractility before induction of anesthesia, you can actually do a quick transthoracic echocardiography when the patient is in operation theater on the table, and can plan your anesthesia accordingly. Now, the nomenclature for the ultrasound examinations are varies a lot. And first thing is the handheld ultrasound examinations. Nowadays, we have a handheld small device which can be used by a basic echocardiographer to an advanced user to get some information about the heart. And there is also something called the point of care POC transthoracic echo, and the different names it has, like focus T, limited T, goal directed T, bedside T, basically mostly the same thing. Again, this can be done by us, the cardiac anesthesiologist or anesthesiologist, or even the specialist echocardiographers, transthoracic echocardiographers. But the complete transthoracic echo is a comprehensive transthoracic or a formal TT exam which we request for a cardiac case, that is mostly almost always done by an advanced echocardiographer or an expert in that field of TT only. So there are different terms again for the focused cardiac ultrasonography. I'm not going to talk about that, but the principle, the way they are used, and the information they provide us are mostly all the same. So basically, we can tell it like a point of care ultrasound or a focused cardiac ultrasonography, which is nothing but a short, focused examination of the heart, not to get a lot of information, but to get few very important information which the anesthesiologist is intended to get for that case. So there are different views which are used for the focused cardiac ultrasonography, like 5-6 usual views do: parasternal long axis view, parasternal short axis view, apical 4-chamber view, subcostal 4-chamber view, and subcostal IVC view. And what are the clinical indications? To look for the function of the heart, to look at the valves, to look at the effusion around the heart, and also to look at the volume status of the patient. And plenty of pathology can be diagnosed from these views only, like any ischemia, hypovolemia, low SVR, any cardiomyopathy, tamponade, and aortic dissection, aortic stenosis, HOCM, lot of pathologies can be diagnosed even with a focused cardiac ultrasonography. And I'll just quickly go through the basic 4-5 views of the transthoracic echocardiography. This is the parasternal long axis view, or PLAX. Patient will be in the supine or left lateral position with the upper arm extended, and this probe will be in the second or third intercostal space in the left sternal border, and the transducer marker, this green light, will face towards the right shoulder. And then then what you get, this is the this is the view you get. This is left atrium, this is left ventricle, this is mitral valve, this is aortic valve, this is aorta, and this is RVOT. So this is parasternal long axis view. And this is again the parasternal long axis view. You can put color here, and you can find some pathologies like any regurgitation, any valvular abnormalities. You can also see the ventricular, left ventricular function and contractility, the right ventricular outflow tract contractility. All these things can be seen here, and collection around the heart can also be seen from the PLAX view. Coming to the parasternal short axis view, and the patient will be in supine or left lateral position again, and again the probe will be on the second or third intercostal space, again in the left sternal border as in the PLAX view, but you need to rotate the probe 90° from the PLAX view. Like for the PLAX view, the transducer was facing the right shoulder. Now you rotate the probe to 90°. Now the transducer will face the left shoulder, and the view is what you get is that you can see my movement as I'm from, you can slightly tilt and you can make up and down. You can see my movement of the probe from PLAX view. 90° movement towards the left shoulder gives you the parasternal short axis view, and it is, you get it in 4 levels: aortic valve, basal level, mid level, and apical level. This view is particularly important because parasternal short axis view at the aortic valve level, for that you need to slightly tilt the probe and slightly maybe put the probe slightly upward, and you can get this left atrium, interatrial septum, RA tricuspid, and the RVOT and PA. This view is particularly important to look at any pathology of the aortic valve, any pulmonary valve, any pulmonary embolism, and those kind of pathology can be quickly detected by this view. And for the parasternal short axis view, basal and mid level, from the aortic level, you need to slightly tilt the probe down, upwards down, then you will get the basal and mid level. The basal level as can be diagnosed because you can see the mitral leaflet, and the mid level you can see 2 of the papillary muscles, anterolateral papillary muscle and posteromedial papillary muscle. And as you know from this is a very important view to detect any regional wall abnormality, any collection around the heart, and you can also diagnose any hypovolemia, any low SVR. Lot of information, any hypertrophy of the heart can be found from this view. And coming to the apical 4-chamber view, patient will be in the supine or left lateral position, again in the upper arm extended. Now you need to take the probe into the 5th intercostal space. You need to palpate the maximal thrust of the apex of the heart, and at that point you should place your probe, and this transducer should face towards the right side at 3 o'clock position, as you can see in this case. So what you get this 4-chamber view, beautiful 4-chamber view. This is the left atrium, left ventricle, right atrium, right ventricle. This is nothing but the inverted mid-esophageal 4-chamber view of transesophageal echocardiography. And you can put color and get a lot of information about the heart function, any collection around the heart, any pathology in any of the chambers of the heart, everything you can get from the apical 4-chamber view. Coming to the subcostal view, here the patient should be supine with the knees flexed. As the knees are flexed, you get a better subcostal view, and the probe has to be held right to the midline. If this is the midline, the probe should be held right to the midline, and here this is the right side, sorry, this is the here, so right to the midline, and between the giphisternum and mid clavicular line, this is the giphisternum, this is the mid clavicular line, so in between giphisternum and mid clavicular line, and transducer marker facing towards the left hip horizontally. This is the ideal position to get a subcostal view, and part of the lever seen adjacent to the probe. Actually, you can ask the patient to take a deep inspiration and you need to press the probe very tough, very tightly down. Then you get a better subcostal view, and you can see you almost get a view similar to the 4-chamber view, bit of tilted, but the information you get almost all the same. In many of the patients, with obese patients, any dressings of the surgical dressings, emphysema, you may not get a apical 4-chamber view very well. In that cases, you can get a subcostal view, and sometimes subcostal views are the only view available in the transthoracic echocardiography post cardiac surgery to diagnose any gross effusion or pericardial tamponade, because no other views you get. The IVC views are very similar. Patient supine and mid to right to giphisternum, place the probe. The marker will now face upwards towards the head. The marker will now face upwards, and we get the IVC view, and you can see the lever here. And you can measure the IVC 1 centimeter from the IVC RA junction. So established conditions or the risk factors for postoperative mortality diagnosed by TTE. As we know, like systolic dysfunction, any gross regional wall motion abnormality, any valvular heart disease, particularly anything severe like severe AS, severe MS or severe MR, diastolic heart failure, hypovolemia, severe LV hypertrophy, a large and grossly visible intracardiac masses. These are established conditions for postoperative mortality. And conditions diagnosed by on POC, point of care transthoracic echocardiography, you can diagnose plenty of conditions, including, as I said, any poor heart function, LV and RV, any valvular heart disease, any undiagnosed shunts like ASD, VSD, or through PFO, any pericardial disease, degree of the diastolic dysfunction, any thromboembolism in the pulmonary arterial tree, any thrombus inside the heart anywhere, maybe in the but the left atrial appendage is not visualized by transthoracic echo, so it can't pick up that, but anywhere in left atrium, anywhere else, or LV, RA, RV, it can pick up clots. Also, you can see the pleural effusions and pneumothorax, hypovolemia, any vasodilatation in low SBR conditions. By point of care TTE, you can diagnose any gross pericardial effusion and whether it's causing tamponade, and peri-ARS situations all can be diagnosed by the point of care TTE. So it's quite useful. And some conditions which causing hypoxia can be diagnosed by POCTT as well, like any SUNS, primary ASD or PFO causing right to left shunt. You can do a bubble study to diagnose a hidden PFO or ASD. Any pulmonary embolism, you can see any gross collection around the pleura causing the collapse of the lung. You can do a lung ultrasound as well to diagnose any pneumothorax, any pulmonary hypertension, any you can diagnose B lines if the heart function is bad, if there's severe acute MR or AR. So all these things can be causes of hypoxia, and can be diagnosed by a point of care transthoracic echo. And these are different hemodynamic point of care calculations, because hemodynamic point of care TTE is not a complete examination, and you need to do ideally within 5 minutes or maybe 5 to 10 minutes to get very focused information you are wanting to know. So you can get some numbers like fractional area shortening, some ejection fractions, biplane ejection fraction of the LV. You can get the fractional area change of the RV, and also TAPSE is very easy to do by transthoracic echocardiography. You can also get the cardiac output. You need to measure the VTI across the LVOT in 5-chamber view and the LVOT in 5-chamber view. And for the volume status and low SVR, you need to go to the parasternal short axis view, mid papillary short axis view. You need to take the left ventricular endostolic area and fractional shortening or fractional area change. With these two things, you can tell whether patient is hypovolemic or patient has low SVR. And obviously IVC, routinely we check the size and collapsibility to see whether patient is volume responsive or not. And there's a few quick guides for the gross pathologies. I don't think it's a cardiac anesthesia or any cardiac classes, so no point of discussing all these things. If any during the discussion, we'll discuss any pathologies or anything that that is asked. I think that concludes my presentation. Thank you very much for kind attention.
Thank you, Dr. Aruk, for that excellent presentation on the role of TTE as applicable to cardiac anesthesia and anesthesiology. Is very well done. You have shown the important views which are used as a point of care ultrasound procedure. Thank you so much.
Thank you, sir.
Now I request the panelists to switch on their videos and comment, question, or add points. Actually, we had 5 different topics. One is about the recent advances in pulmonary artery catheterization. Then we had the deep hypothermic circulatory arrest. Then we had a review of low flow, low grade aortic stenosis. Then PICO methodology for cardiac output determination. And then we had the transthoracic echocardiography as applicable to anesthesiologists. With that, the floor is open for discussion, questions, and comments.
Yeah. First, Dr. Abhinandan, can you enumerate recent indications according to the ACC guidelines for use of PA catheter?
Yes, the thing is that regarding the PA catheter was only in the year of 2000. After the 2003, there is no current guideline as of now, but only there is a 2021. There is a Chinese Society of Anesthesiologists. They have also just enumerated the more or less the same list, that is the safe ASA 4 and 5 stage of patients, and also high risk of cardiac surgery patients. And if there is a patient is having impending requirement of yes, that is respiratory assist device, and if the patient is having any LVAD or BiVAD or RVAD implantation requirement, if the patient is having any sort of undiagnosed pulmonary arterial hypertension, whether to distinguish whether it's a pre-capillary or post-capillary. These things are the most common scenarios that we can use PA catheter nowadays.
Thank you. And for the newer graduates and students, since we are not using regularly PA catheters, how many should they insert or see before they are comfortable with the use of PA catheter? Is there any number or
Yes, Professor Jeremy Swan actually he advised us that at approximately 50 PA catheter per year, at least. We said it should be a good number to practice it for the cardiac anesthesiologist to just to go through the all the values and all the parameters regularly so that whenever in need he can just go for interpretation of this all those rules and all and do the requirement for that patient.
okay? And in your talk, you said that it does not reduce the hospital stay or mortality.
Yes,
So,
as per the meta-analysis study, ma'am.
okay, what may be the reason?
Because of for the meta-analysis they have taken the study for the from the long back. From that time there was not use of this current generation PA catheters. There was use of only first generation, second generation catheters. First of all, there was a multiple studies in that meta-analysis. They have mentioned as a limitation that those studies has been done to those patients who are actually the PA catheter has been put in a more delayed time whenever the patient has already decompensated. So that moment of time, if the PA catheter has been put for the monitoring, so that does not account for the fault of the PA catheter. So these are the parameters that we actually need to reanalyze for the current scenario, because in current scenario there is a urgent need for updated guideline regarding the use of PA catheter, because that only 2003 guideline ASA, that is the last guideline that we have right now for the international acclaimed guidelines.
I would like to add a couple of points here. In the management of cardiogenic shock, it has been shown that PA
Yes,
catheters
yes, sir.
definitely help. And if the patient's condition is not improving, it's better to have a PA catheter data early in the course of the disease process rather than late, so that you can get valuable information and also decide upon whether you want to use mechanical circulatory assist devices. The decision is also based on the use of the PA catheter data. That's one comment I would like to
Yes,
make.
sir.
Another one is there's what is called a SWAN IQ, where you get the right ventricular pressure. You actually showed the waveform, and here we can get the right ventricular cardiac output on a continuous basis, which is not dependent on thermodilution technique. Just from the RV waveform, the thermodilution, the cardiac output is determined without using the thermodilution technique. I just wanted to point out this one. Do you agree with that?
There is a using an exponential decay time, sir, of your RV waveform, pressure waveform. I'm not
RV
getting your
pressure
question, sir,
waveform,
actually.
from RV waveform, the pressure data is converted to flow data using artificial
Yes, sir.
intelligence, and you get a continuous RV cardiac output.
Yes, sir. Okay.
Okay.
And there is a upcoming technology also, admittance technology that is being animal study is being done right now, sir. So they give a intermittent, not an intermittent, that is a instantaneous RV pressure volume loop that they will give, and they will actually tell us exactly what the patient will respond to phenylephrine and dobutamine and in different scenarios. But currently it is only in animal studies right now, sir.
Right. Other comments and questions?
Dr. Sohini? Dr. Sohini is there?
Yes, ma'am.
Hi. So, do you use any other monitoring devices when you do aortic arch surgeries during deep hypothermic circulatory arrest?
Ma'am, we have only seen the use of NIRS in our institute, but you can use other like SSCP, MEP, all these things can be used. But in our institute, we have only seen NIRS being used, nothing else.
Okay, so have you noticed about the NIRS anything when there is, issues with the cerebral circulation?
Yeah,
And
yeah,
how do
yeah.
you go about it?
There is a drop in the RSO2, so that happens sometimes in cases of complications and all. So
And
we
how do you
try to.
address it?
Ma'am, actually, in cases of TCA, usually the drop, whatever cases, it's not like we have had major cases of DHC. I have seen during my residency, I have seen one or two cases, and another one I have seen post residency, that was antegrade cerebral perfusion was used, so there it was maintained. Nothing we did not really whatever was written in the book, we followed everything, like all the precautions were taken. But then the patient did not really have any sort of major neurological changes in the post-operative period. So probably it is not so accurate also.
So
But there
basically,
was a drop.
so basically you do a baseline NIRS
Yeah,
when the
yeah.
patient
Trend
is
should be
awake.
followed. Yeah, yeah. Trend
So
is more important.
so any drop in like baseline can be even 48 sometimes.
Yeah, yeah, yeah. More than
Yeah.
20% we consider it
Yes.
significant.
Yes.
But usually, like post-operatively, we've not seen any major this thing changes.
So intra-op, when they are
Yeah.
handling the aortic arch and
Mhm.
they are trying to give through the common carotid or the right common brachiocephalic. So
Mhm.
what happens is they are trying to perfuse the one of the common carotids, and then you see there's a drop of saturation on the left side. So basically there's an issue with the circle of
Circle
Willis,
of Willis.
which is quite common. So it is recommended that you do a a CT or an
Angio.
MR pre-op in complex cases, so that the intactness of the circle of Willis is prior established rather than on table, because on table when it happens, then you have to cannulate the left common carotid and separately perfuse it. So
Yes.
NIRS comes very handy in such
Yeah.
situations. Okay.
Absolutely.
And also monitoring devices like the Massimo monitor has this, color coded waveforms where, you know, um, it predicts intra-op stroke rates and everything, and also
Okay.
transcranial dopplers. So
Yes.
we have fixed transcranial dopplers which will show a lot of thromboembolic events intra-op. So the reliability, I am still not very sure, because a lot of embolisms happen intra-op, but patients wake up.
Yes.
But
Yes.
yes, so the NIRS, yes, it does come very helpful, especially when you're doing ACP, and you'll have to do selective cannulation of the neck vessels in case you're doing the aortic arch completely. Yeah.
Can I add something to this?
Yeah.
So transcranial Doppler is a very beautiful thing for this SCP and RCP, because even if you're giving SCP or RCP, whatever, still it still can set some air bubbles or some debris, whatever. And the beauty of the TCD is that it can differentiate with a micro bubble, it's a small air, to a big particle. So the signal will be absolutely different. And you can actually, for the 20-30 minutes, you can actually, there's some devices where you can put the probe fixed to this area, and continuously you get those things. Very interesting to see actually. And as you rightly said, with this new Massimo SedLine monitoring, there is bilateral color spectral display. And because if there is a color change, drastic color change, obviously the deep hypothermia, and you have given thiopentone, everything, there will be drop in electrical activity in the brain. But if this is not symmetric, as the color coding says, some in some hemisphere it's completely down, completely blue green, and other it's like yellow red, then the disparity tells you that something wrong is happening. we need to alarm the surgeon that something wrong is happening. So a lot of new things coming.
Thank you.
Even with the
Yes.
ACP,
Yes.
what should be the safe period of arrest for DHCA case?
It allows till like 45 minutes. That's what studies are saying, not beyond that.
Occasionally, surgeons delay beyond that.
Yes,
So
yes, yes.
I
But
wanted.
ideally, like around 45 minutes. Because they usually like cool till 20, 22 degrees. They don't go till 18 degrees.
No, they do go till 18 degrees. So in our setup, we've got
Okay.
DHCA, and though you did not cover that, but then DHCA has become, routine kind of thing for all these complications that are occurring. So we've got a number of cardiothoracic, residents. So putting in cannula, removing cannula. So a number of times there has been dissections in the aorta, and for all those immediate complications that occur, so we commonly go for DHCA, and a number of times it is unplanned also. And but then I have seen that with all these pharmacological protection, with cooling, with extreme cooling, with monitoring, and with all these, the results are quite good. It is not like that. Even if see, the thing is that you also mentioned that even if it goes beyond 45, in the intermittent phase they give a bit of
Yeah.
perfusion.
Yes, yes.
That also helps. So it is not alone that it is one stretch of 45 minutes. It depends on the procedure, on the patient, on the inherent pathology, how much time, what is the surgeon like, also all these things, they play an important role. And I think yes, this newer monitoring tools like TCD and yes, NIRS is something that each one of us is doing. But with advent of TCD, there are. But I still don't know. Means if suppose you've got emboli, how do you manage? Arupa was saying. So what do you do if you see those emboli in TCD? What do you do?
So if this is a minor gaseous emboli, not to worry much. I mean, just to make sure that it's not persistent. If this because if there is a calcium or some big debris, continuously the color will change in TCD. It will continuously give signal with a big noise. In that case, probably
intervention like
you can probably give a
down
I mean, yeah, those things, and giving a shot from the venous side. If the emboli you are
Retrograde
creating from
focus.
the arterial side, give a retrograde to the venous side and to wash out this emboli. Maybe those things you can do. And if
Yes.
that emboli along with that low NIRS, because NIRS is mandatory,
yeah, and I
in that case you can do that.
something we all are doing.
Yes, it's like if there's a massive air embolism, God forbid, on a CPB, how we go ahead, like could give the head down and then just flush the SVC, use the SVC cannula to wash out the air from the head. So something like that, they do suggest. But yeah, similar questions I've asked in multiple forums. So the neurologist very clearly told me that even if you have high suspicious of any embolic events intra-op, then it's best to take the patient to CT scan and see where the block is, so you can immediately do a balloon, or you can thrombolyze. It is a very
That
pros and cons are there, but
that
this is what they have recommended.
not for air, not for air.
Not
That
air, ma'am.
thrombus.
Yeah, thrombus
Yeah,
event. Because we have big aortic arch surgeries
yeah,
where
yeah.
a big layer of thrombus is sitting in the aorta, and that can, because of various sandblasting effects and, because of cannulations, the thrombus may get dislodged to the brain. So in such events, if we are suspecting any embolism because of clots, then the earliest CT scan can help in early intervention. and we can save the brain. That is what they have told. But it's very rare that people take the patient to CT scan immediately after surgery. But I think that 24 hours, the first 24 hours is very crucial. So intra-op TCD monitoring and the high suspicion of a big emboli which could have embolized, then that can come very helpful. The post-op early intervention, CT intervention.
That's true. That's true, because in one of the aortic arch cases I was doing, and after the CPB was off, one side, right side, I mean, because we do carotid cannulation in all these cases of aortic arch cases and ascending aortic cases.
Please
Then,
definitely.
then, in one side, the NIRS dropped down and was not recovering for a long time. I did all sorts of things medically, and the postoperatively patient didn't wake up. So, I mean, probably the persistence of a very critically low NIRS value, that we
So
should
that
do
is
immediate
that,
imaging.
there are some studies of that also, and we also had a similar case. But then it was like, if it is like for more than 20 minutes, that drop
Yeah,
in the other side, if that persists more than 20 minutes, then and it is not recovering with your interventions, then outcomes are actually bad.
yeah,
Yeah. This is the area of under curve which is more important. What is the
Yes, yes,
duration and the magnitude of drop? Both are important.
yes, sir.
So both should be considered. As far as the duration of DCA without ACP or RCP, if it is up to 30 minutes, it's fine. But if it's expected to go beyond 30 minutes, you need to have these additional adjuncts like ACP, that is antegrade cerebral perfusion, or retrograde cerebral perfusion. Usually nowadays, antegrade is preferred over retrograde. As correctly pointed out by Sohali, the risk of cerebral edema is more with retrograde, so you prefer to go for antegrade. And you can extend up to 90 minutes with antegrade cerebral protection, taking care of the fact that you're monitoring the pressure as well as the neurological monitoring in terms of RSO2, that is regional cerebral oxygen saturation.
I just want to know, anybody's practicing epidural cooling for spinal cord protection.
It is described, but I have not seen anybody doing it. That is for aortic aneurysm surgery, especially thoracoabdominal aneurysm, where you are worried about the spinal cord perfusion. It is described actually. We have not done it. I think Parimala, I think their center they have used it because I remember Prabhu Shankar saying that one day.
Earlier we have done, but these days only CSF drainage is used. Epidural cooling with 500 to 1000 ml was done in the 20 years back.
20 years.
Now these days endovascular surgeries are done, repairs. So rarely we need all these intensive measures for cerebral spinal cord protections.
Any questions to the low flow, low gradient aortic stenosis?
That was a beautiful lecture, I think.
Good, it was quite good. Yes.
And everyone needs to differentiate these operability criteria, and knowing that the gradient is less with dilated heart. I think that is the crux that everyone needs to know when the heart decompensates after AS. And this is quite a common scenario, not so uncommon.
Yes. Any questions on PICO?
So I remember a case. I would like to share this case which we did. So we had a patient post CABG, and we had inserted a PICO monitor for that patient because the patient's blood pressure was very labile, and we suspected sepsis. his HB kept on dropping. There was no collection in the mediastinum, no collection in the pleura, nowhere. But HB kept on dropping. We kept on chasing volume. That is when I realized not a single monitoring, but multiple monitors and multiple skills of the anesthetist will come into picture. So a quick scan, when I was just trying to do the scan of the IVC, we picked up there was perihepatic collection. So what had happened was the drain had gone through the liver. Again, as madam said, when you are working in a institute where juniors are just starting to work, so the mediastinal drain had actually passed through the liver, and the liver was bleeding continuously, and it was being collected in the abdomen. And he was an obese guy, so you couldn't pick up the abdominal distensions very early. So that ultrasound came very handy. So what I would like to emphasize is always use your ultrasound probe. It will always come to your rescue. Scan the lungs, scan the heart, something you'll pick up if you're in a very dicey thing. We didn't have we did have a PA catheter in place for that patient, but again the readings were all questionable. So it was like sepsis, where are we losing, why is the HP dropping. So it was being collected in the abdomen. Then we re-explored him and everything became normal.
So I think, so I usually use the Pico in a mixed situation, patient with a low cardiac output along with sepsis. So these are the situations which are difficult to treat without invasive monitoring. And as you know, that low cardiac output and sepsis both has the propensity to flood the lung to cause increased pulmonary edema. And Pico is actually, because I have used a lot of Pico monitoring actually. So Pico is a beautiful, beautiful monitor. I like the monitor a lot. Even in VA ECMO, in lung transplant patients, I have used the Pico monitor. Although in VA ECMO, most of the parameters are not validated, but still you can see the trend. So studies have been done also regarding the Pico parameters in VA ECMO. It has been seen that like 6 to 7 times, but still there is some correlation. Particularly it becomes useful in ECMO when you are in low flow. In venovenous ECMO, it's not a problem. For VA ECMO, if the flow is low, particularly during weaning, 0.5 to 1 liter per minute, in that case Pico is helpful. Pico is a very good monitor, but it's equally expensive. Like for a CCO combo cardiac output catheter, PA catheter, it's like 21,000. I think Pico catheter we used to charge like 25,000, if I'm not wrong.
There is a question on the use of PA catheter in cardiogenic shock. And my response to that question is that if the patient is in low cardiac output, the filling pressures are high, but the perfusion is poor and not actually responding to the optimal dose of inotropes or vasodilators. It's a time to use the PA catheter to know what is happening in terms of cardiac index, systemic vascular resistance, and pulmonary vascular resistance, etc. All the derived parameters looked in, and the literature supports the use of PA catheter in these patients. What's your response for this, Dr. Abhinandan?
Yes, sir. We actually use PA catheter for most of the CABG cases. We
Do you
usually,
use for all patients, CABG?
usually, sir, in our center we do the MICS for the over 100% patients.
Yeah.
So for these patients, we actually use for our settings, we use both T and PA catheter, both.
For all MICS CABGs.
Yes, sir.
I see. That's good information. Thank you for that. And
I think it will also help, sir, if we have a PA catheter along with the pacing wire, because in MICS, pacing wire again is a big issue. So if the PA catheter is associated with pacing facility, then we don't have to insert an additional sheath for a TPI. We can use the PA catheter itself as a pacemaker.
Any responses for that?
Sir, if I may add one point with regard to the
We hardly use PA catheters for MICs. We very rarely use it unless there is a patient is deteriorating or patient is having a poor LV function to start with, where you put a sheath and keep the sheath as a standby to deploy a PA catheter if the patient actually worsens. That is the strategy we are following it. Elvis, tell me what you wanted to say something.
So one thing which I would say is that the pulmonary catheter is going to help you if there's like a right heart versus a left heart failure, or you're like confused about a mixed etiology. From a pure cardiogenic shock versus like you have a cardiogenic shock in a patient in the ICU who has like also query sepsis, or you're having wondering if there's some other problem, then a pulmonary artery catheter is going to be useful, especially if you're going for an LVAD or like more advanced mechanical support, as opposed to just having a pure cardiogenic shock secondary to a ACS.
CPA catheter is useful in all high-risk patients to get the detailed hemodynamic information, which is going to help you in the management, ultimate management of the patient. But routine use is not really advocated as far as the consensus goes.
Actually, sir, as I say,
And also it goes by the institutional practice. If somebody is using
Yes, sir.
PA for all mixed cases,
Yes.
it is the institutional practice.
Absolutely.
There is no criticism on that.
yeah.
As far as the consent is concerned, routine use is not indicated, and specific indications are the presence of pulmonary arterial hypertension, poor LV function, severe diastolic dysfunction, especially restrictive pattern, and use of LVAD and other mechanical support devices, etc. There it is useful, and also specifically when you're weaning ECMO, ECMO, PA catheter also is a very handy tool.
Actually, sir, in MICS, the problem, what happens with this one lung ventilation, sometimes the increase in PA pressure is so much. So without a PA catheter, sometimes it becomes difficult. That's why routinely it's our institutional practice, strict.
So we are not criticizing. That's what
yeah. So
It's about optimizing ventilation.
that's the main reason. Because for the one lung ventilation, sometimes you have seen the PA pressures are fine, sometimes the PA pressure goes up because you're using in all cases. So different variations and all, and accordingly we can mostly for the interop purpose. It doesn't help.
Why don't you document that? You put the PA catheter for all patients at MICS, Institute One Lung Ventilation, and document the increase in the PA pressure. How many patients do actually get the PA pressure, or what is the degree of elevation? And does it come down as the pulmonary hypoxic vasoconstrictor reflex becomes active and the PaO2 actually starts to improve? Does the PA pressure actually come down? All these things can be documented. As far as I know, there is no study which is, I don't,
Yes, sir.
not read
There is
about
no study, sir. That's why I have given my my student, the DRNB student, this topic. So we are measuring the all PA pressures before one lung, after one lung, correlating with the right heart function, along with the preoperative lung function test. So we are seeing a lot of correlation, preoperative lung function test.
Yeah, actually, you can study the RV function using the transesophageal echocardiogram.
Yeah. Yes, sir.
And
That thing we
see
are
both
doing.
the lines. But we do MICs on a routine basis, and also we use one lung ventilation for robotic cardiac surgery. And 99% of the time, we have not had any problem
No.
with regard to PA pressure, but we have not checked it. Actually, it's easy to say that we didn't have any problem, but we don't have any documents evidence.
Yeah. In many cases, there will be no problem at all.
Document that and demonstrate. It will be useful information.
Sure.
Any questions for TTE presentation? Ruprathan brought out the good point that it should be used whenever needed in perioperative period to look at all the various not only structure but also physiological function of the heart in terms of valvular function, contractility, etc., volume status.
Yes. Preoperatively, should all anesthetists be doing evaluation with the help of transthoracic echo? What is your
Anesthetists obviously should know how to use the transthoracic echo, but preoperatively, routinely, you need not do that. If you only suspect that you need to, there's the something happened to the patient in last few days from the last echo has been done, and you want to look at the volume status or you want to look at the RV function or contractility. If you have some suspicion in your mind, you can always put the probe. It's just a matter of 2 minutes. You get all the information. Just eyeballing.
Nowadays, I think this is what we are practicing. All the residents, I really encourage that they should all do pre-operative kind of thing, just because they have to do it in post-operative period
Yeah.
in all these patients.
Preoperative means when the patient is on the table or it's much before
But
the.
is why we are doing it on the table. It hardly takes another 5 minutes or so to have that quick scan, so that the resident, he knows what are the pre-operative findings, and he has to see them in the post-operative period also. So all that guidance becomes, first of all, the learning of the resident, and then all the patient characteristics, and then immediate management in the post-operative period with respect to volume therapy, with respect to inotropic management. I think that has changed the scenario quite a lot.
That's right.
Yes.
That's a good practice. Actually, I would encourage the TT to be done before you actually start the case.
Always, I think.
But actually, what happens in centers like ours, where there's pressure to start early, so
So shift
we hardly do it. I think we should start
and
doing
then you have to keep the surgeon in confidence.
Yeah,
So,
yeah.
and
Actually,
then we are seeing the patient in the post-operative period also. So earlier, to begin with, there was a bit of resistance, but nowadays the surgeons, they are like, okay, just because they are also learning, their residents are also learning.
Rachna,
CPS residents
just
are
one
also learning
question.
to manage in post-operative period. So
Yes.
I think that is changing a bit of scenario in my setup, in my OT at least.
Sure.
Rachna, just one one question. Because you will be after induction, so you are doing it just on the table pre-induction. After induction, anyway, you are going to do TOE, which is giving you better information. So why you want this TT to be done? Just to reconfirm the diagnosis, or but anyway, they are doing a point of care ultrasound to challenge the cardiologist with the previous diagnosis
It is
by the POC, by the residents
that
will
we
be
can
very
do by
difficult.
T. Challenge the cardiologist by T,
The
not by
I
transfer,
can
I say
answer
per
the
se,
question.
because a number of times there are controversies, and we do challenge the cardiologist with all those things, but that is by T, not by transthoracic. But that is altogether a learning, just because in post-operative period, this management goes hand in hand. If they don't practice, so they don't learn. So
I
I
would
think
like to
that is
add
the
a point
only
here.
take-home
We are
message
running
for
out of
everyone.
time, but I would like to add a point here.
And it has been of great help, great help. This transthoracic thing has helped us tremendously,
Sure.
especially in ICU.
See, sometimes we usually do the on-call ECG before the patient is wheeled into the theater. The ECG is done, and if there's a fresh ECG abnormality, it's mandatory to do the echocardiography to see whether there is any new regional wall motion abnormality, which actually increases the risk of surgery. This can be I mean, communicated to the surgeon as well as the maybe explained to the patient. This is one benefit of the doing echo before actually starting the case. The other one is that You're also training the candidate to do the transthoracic echocardiography and quickly assess the heart, both in terms of cardiac contractility as well as valvular function, so that whatever findings which are missed in the preoperative phase, for example, most of the reports do not contain the information about the ascending aorta plaques and the ascending aortic annulus, and sometimes the trivial or mild aortic regurgitation is not mentioned, and you find it on the table when you do the TEE. So in the presence of aortic regurgitation more than mild, you cannot use intra-aortic balloon pump. So such information may be important for the team to know in case of deterioration what to do.
So
Yeah.
I think sir, my preoperative on-table TTE transthoracic echo, it's mostly just to check, make sure whether to check the volume status and to basic eyeballing on the contractility, and something grossly abnormal is not there. Anyway, we are then based on that information that
And most
ICC.
importantly, new regional wall motion abnormality that will alter the prognosis straight away.
Yes, absolutely. And if that RWMA in a specific, not random RWMA, if that RWMA is correlating with the ECG changes, that means definitely active ischemia is there, and patient may need a balloon pump or patient may go into CPP. That's a bad sign. But that should be correlation between the RWMA and the ECG changes.
Of course, ECG goes hand in hand. There is one question from Umani. Transthoracic echo is useful post pneumonectomy to check the RV dysfunction. I think this is a comment, and I do agree with it.
Yeah.
You agree with that, Arup?
Yes, obviously, a pneumonectomy causes RV dysfunction, and you can look at.
I think the diastolic dysfunction grading is very helpful, especially when we are doing off-pump cabbage. That is always overlooked. So if we have a prior idea about the diastolic dysfunction of the heart, then it helps in the better management and drop.
Sure. That brings to the end of today's webinar. I would like to thank Dr. Parimala, Dr. Pooja, Dr. Rachana Wadhwa for being with us for the last 2 hours and providing us the insight into the various topics we have discussed. I would like to thank the presenters, the Abhinandan, Sohini, Debjani, Elvis, and Arup for their excellent deliberations and high
Thank you,
quality.
sir.
Thank you so much, and we would like to have you once again. And we have just announced the dates for next IACTA TE in August next year, 2026. The dates are 19th to 23rd. Please join us. And we will be doing every first Wednesday ICA webinars relating to cardiac anesthesia. Please do join us and provide your valuable inputs and discuss with us about the various aspects of patient care when we deal with patients. With that, I would like to thank everyone on behalf of ICA and looking forward to seeing you sometime soon.
Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you,
Thank you
sir.
so much, sir. Thank you
Good
so much.
night. Good night.
Thank you, sir.
Thank you, sir.
Thank you so much, everyone, for joining this session. Clarnet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone.
Thank you so much. Thank you.